Hey, this is Lynn Nguyen, Associate Medical Director for Redfield Medical Direction. This is our protocol review for January 2025, and we'll be focusing on behavioral emergencies and caring for patients in law enforcement custody. Behavioral emergencies can be particularly challenging because the patients themselves can be obstructing the medical help that they need. The situation can be further complicated with involvement of law enforcement. Unfortunately, when these situations are mismanaged, the consequences can be really severe. The public is always watching to see how EMS handles these patients. Patient mismanagement end in severe and serious civil and criminal liabilities for you and the agency. High profile cases, such as the ones involving Elijah McClain in 2019, have drawn national attention to the role of EMS in law enforcement custody incidents. I'll be briefly reviewing that case after reviewing the medical approach to behavioral emergencies. I'll wrap up by going over things you can do to avoid the convictions and sentencing like those involved in Elijah McClain's case. When it comes to dealing with behavioral emergencies and patients under custody, it's not just about minimizing your legal risk. It's about ensuring the best possible outcomes for our patients. It goes without saying that every patient, whether or not they are in custody, has the right to medical care. In some situations, law enforcement may prioritize custody over medical needs. A part of our job as EMS is to explain to LEO the necessity of medical intervention and shift the focus back to patient care. The most common behavioral patient you'll deal with will be the intoxicated patient. You've seen this type of patient so many times, you already know to check for the pinpoint pupils, maintain the airway, and give oxygen as needed. Obviously, respiratory depression is the primary concern in these cases. On the other end of the spectrum are the patients experiencing delirium with agitated behavior. These patients require immediate attention. For the sake of the safety of everyone involved, there's a low threshold for chemical restraint if the patient isn't responding to verbal commands. You can use physical restraints to help with administering chemical sedation, but the restraints need to be released as soon as possible. Restraints are a safety tool and should not be used punitively. Never restrain a patient in a prone position that can compromise their airway or breathing. If physical restraints remain during transport, law enforcement must accompany the patient during transport. Cardiac monitoring, a forelead, and end tidal are also absolutely required once the patient is more cooperative. Your primary responsibility is always to ensure safety for yourself, followed by the patient. If a patient is agitated or combative, work with law enforcement to de-escalate the situation. Remember that you make the medical decisions, not LEO. Patient care should be guided by our protocol and your clinical judgment, not LEO's priorities. As a reminder, you cannot medically clear patients in the field. If a patient requires medical evaluation or clearance, they must be transported to an appropriate healthcare facility. If LEO resists medical interventions or transport when it's needed, at least try and explain to them why treatment is critical. Document your interactions with LEO in your notes, detailing the refusal or cooperation by law enforcement, along with your rationale for patient care decisions. If you can, include the names and badge numbers of the officers involved. What happens if you don't step up when you're supposed to? In the court of law, that could be seen as medical negligence. There are 4 elements that make up medical negligence. First, the provider must owe a duty of care to a patient. Second, the provider fails to meet that duty of care. Third, the patient was injured because of that failure. And lastly, there was a clear connection between the failure to care and the injury. EMS providers can face negligence claims if they fail to provide appropriate care, such as delaying transport or failing to intervene in a life-threatening situation. There may be times when LEO specifically tells you to ketamine a patient and you don't feel like it's appropriate. Using restraints and sedation without medical justification could be interpreted as battery. If you fail to monitor a sedated patient or ignore signs of respiratory or circulatory distress, this could be considered gross negligence and result in criminal charges if the patient dies. All of this could lead to financial penalties and public criticism for both you and the agency. If you fail to adhere to professional standards, the state medical board and EMS regulatory agencies can suspend or revoke your license. Obviously, this would be bad for your career. EMS providers in these situations can not only find themselves without a job, but also with a hard time being hired for another gig because of the red flags on their record. By now, everyone should know the case of Elijah McClain, the 23-year-old who was detained by officers in 2019 while walking home from a convenience store. In short, law enforcement approached Mr. McClain and physically subdued him. Afterwards, medics arrived on scene and were led to believe that McClain was, quote, acting crazy, definitely on something, and had incredible, crazy strength. Officers were giving this report to the medics while McLean was still subdued and making coherent remarks. The decision was made to administer 500 milligrams of ketamine to McLean. Eventually, someone finally noticed that McLean had no pulses, and he ultimately expired 6 days later. There are so many takeaways from the body cam footage, but we'll just mention some key learning points here. For starters, we would expect a more accurate clinical assessment from medics, independent of the report given by officers. In the court proceedings that followed, the defendants would claim that McLean was experiencing excited delirium. First off, this is not an actual diagnosis that any governing medical body recognizes. Second, McLean's verbal responses were appropriate and inconsistent with any diagnosis of actual delirium. This case also highlights the importance of weight-based dosing. McLean weighed approximately 64 kilos. Assuming the max weight-based dosing, he should have received at most 320 milligrams of ketamine. Using our protocol of 4 mg per kg, McLean would have gotten a little less at 256 milligrams of ketamine. For comparison, the 500 milligram dose that he got would have been more appropriate for someone that was more than twice his weight. Third, more than 2 minutes passed after McLean was given a drug that causes respiratory depression before he was moved from a prone position onto a stretcher. To make matters worse, there was no monitor to be seen, which means there was definitely no end tidal. A patient who is about to be sedated needs to be put on the monitor as soon as possible. The legal case that followed McLean's death was unprecedented. A part of the officer's legal defense was to shift the blame onto the paramedics. This was made worse by the coroner's autopsy report, which ultimately listed McLean's cause of death as complications of ketamine administration following forcible restraint. The autopsy report stated that there was, quote, no evidence of injuries inflicted by the police contributed to death. The report continues on to say that the coroner believed that, quote, Mr. McLean would most likely be alive but for the administration of ketamine. Both paramedics were found guilty of criminally negligent homicide. One medic was sentenced to 4 years probation, and the other was initially sentenced to 5 years in prison, which was converted to 4 years probation after he served 119 days in prison. There are 2 major practices to avoid this happening to you. The first is sticking to our protocol and calling medical direction if you need help. The second is strong documentation. This is your number one tool for not only showing your professional accountability, but also for minimizing legal risk down the road. Comprehensive records can be your best defense in legal proceedings. If done properly, your charting can provide an objective account of the patient's condition, the care you provided, and interactions and discussions that were had with law enforcement. It also helps us as medical directors to defend you. Keeping accurate documentation ensures transparency in your actions and clinical decisions by showing that you stuck to protocol and ethical standards. If the time were to ever come, details like officer names and badge numbers and specific discussions or conflicts about medical decision-making will be key in protecting your name and integrity. If it's not documented, then it didn't happen. And that's all for this month. As always, if you have any questions, feel free to reach out by phone or email.